Hello students, this is Dr. Pawlak. I was asked by Professor Matijasik to record this lecture for you. Apparently something is not right with the recording that we have done in Poland, and so I'm happy to re-record this for you. This lecture is about common misconceptions about vitamin B12. Vitamin B12 is my favorite nutrient, so every chance I get, I'm happy to talk about it. Here's what I would like you to get, okay? I would like you to recognize the misconceptions concerning a number of things. Number one, prevalence of deficiency, toxicity of cyanocobalamin, which is one form of vitamin B12, association of B12 with cancer, role of homocysteine in atherosclerosis, role of different forms of B12 in deficiency treatment, requirement of B12 for vegans, and plant sources of vitamin B12. I will begin though with a short background. B12 is a little different than other vitamins. It is very complicated in terms of its chemical structure, and on top of that, it incorporates a metal cobalt in its structure, and that's why it is called cobalamin. Okay, it is possible to make it in the laboratory, but it is a very elaborated process, and so generally speaking, we get B12 from microorganisms, whether we are talking about foods that are fortified with B12, such as, for example, cereal or soy milk, or supplements. The source of B12 in these products is actually bacteria. We have two active forms of B12, methylcobalamin and adenosylcobalamin. In addition to these two active forms, we can relatively easily convert cyanocobalamin and hydroxycobalamin into the active forms. And in addition to these four forms, which I hear called active, even though only two of them are really truly active, we have a number of vitamin B12 analogs, also sometimes referred to as pseudocobalamins. And these are important for bacteria and other microorganisms, but they are completely useless for humans. And we actually ingest these from different foods. And some people believe that they may actually be useful in terms of preventing B12 deficiency, but actually the opposite might be the case, because these analogs may actually interfere with metabolism of true cobalamins or active forms of vitamin B12. All of these, both the active and inactive forms, belong to a group of compounds we called corinoids. In terms of why we need vitamin B12, there are actually a number of different functions, and we in reality recognize a variety of functions as we look at symptoms of B12 deficiency. So I listed just some here. Number one, we need it for nucleic acid synthesis and myelin synthesis, and as well as maintenance, and then the formation of red blood cells as well as other blood cells, and as well as energy synthesis. This is one reason why people who are B12 deficient oftentimes feel absolutely no energy. They would want to sleep if they would be let to sleep night and day. Okay? B12 in foods is bound to protein, and in order for us to actually utilize B12, meaning to absorb it, we need to split B12 from the protein to which it is bound. And we do that by the action of hydrochloric acid as well as pepsin. Okay? Pepsin secreted in the stomach as pepsinogen. The hydrochloric acid actually activates pepsinogen into pepsin, and the pepsin splits or breaks down the bond between B12 and protein. The stomach also secretes a specialized protein known as the intrinsic factor. And the intrinsic factor eventually binds with B12, and that's how B12 is absorbed, through absorbing of the intrinsic factor. That's B12 in foods. If we ingest large quantities of B12, such as, for example, when we take supplements, then some of that B12, approximately 1% or so, may be absorbed through passive diffusion as other nutrients are being absorbed, maybe mainly sodium. Okay, so there are these two forms of absorption. One is called active transport, that's through the action of in the intrinsic factor, and this is subjected to the process I explained, and then the passive diffusion as B12 gets free ride as other nutrients are being absorbed. With that background, let's look at a few myths or misconceptions about B12. Number one, how prevalent is vitamin B12 deficiency? And here is one view on this particular topic. Notice in the frame here, the human body stores several years' worth of vitamin B12, so nutritional deficiency of this vitamin is extremely rare. Although people who follow a strict vegetarian diet and do not consume eggs or dairy products may require vitamin B12 supplements, okay? This is a view that was a prevailing view decades ago. Unfortunately, as you can see here, notice the date here, this was published on March 11, 2021. Some people still adhere to this particular view. Nothing about this statement is actually correct, okay? I listed here 3 different reasons why I consider this a myth. I could actually talk about some others. So let's look at myth 1A. B12 deficiency is not extremely rare. It is actually very common. Then B, humans may or may not store B12 for several years. Regardless whether they do or do not, it is irrelevant. And I will explain this in a moment. And then C, not just strict vegetarians or vegans may require B12 supplements. So let's take one by one here. Let's begin with the first one. Deficiency is not extremely rare, okay? This is from my book on vitamin B12 combating the epidemic of deficiency. And notice I listed more than 20 different groups of people: vegetarians, elderly, patients with diabetes, those with atrophic gastritis, and so on and so on and so on, many, many others. Here is from chapter 3 of that book, where I listed the prevalence of deficiency in different regions of the world. So in California, in one study, 40% were deficient. In Norway, 37%. In Germany, among community dwelling and institutionalized elderly individuals, 25 and 33%. Turkey is an area with extremely high deficiency prevalence. And so on. You can see the other 2 examples here. We could list many other different countries and regions of the world. This is from Dr. Lindsay Allen, who specializes in research on vitamin B12, and who stated vitamin B12 deficiency and depletion are common in wealthy countries, particularly among the elderly, and are most prevalent in poorer populations around the world. This prevalence was underestimated in the past for several reasons, including the erroneous belief that deficiency is unlikely except in strict vegetarians or patients with pernicious anemia, and that it usually takes 20 years for stores of the vitamin to be depleted. And of course, again, this is a view that was held not years, but decades ago. Today, we know what Dr. Lindsay Allen stated here, that it is actually a very common problem. Here's another quote. I have a number of these quotes in the presentation, but they pretty much speak of the same problem. Pernicious anemia is a common cause of megaloblastic anemia throughout the world, and especially in persons of European and African descent. Dietary deficiency of vitamin B12 due to vegetarianism is increasing and causes hyperhomocysteinemia. Dietary vitamin B12 deficiency is a severe problem in the Indian subcontinent, Mexico, Central and South America, and selected areas in Africa. And so it is not the case that just a few vegans here and there may develop B12 deficiency and so may need B12 supplements. No, it is a common problem. Let's look at the other issue. Humans may or may not store B12 for several years. It is irrelevant whether they do or not. Why do I say that? Well, let's consider this illustration. These glasses here represent the capacity for vitamin B12 that can be stored in the body. On the right-hand side, notice the light blue, I guess, color. I guess it's blue, maybe green, whatever color it is, right? Shows that in this particular individual, the glass being an individual here, okay, the capacity is almost filled, okay? Almost 100% of the B12 that can be stored is stored. On the other hand, on the left-hand side, notice that there is no stored B12 in here, okay? The trouble is we never know whether a particular individual that we deal with, particular patient that we deal with, has that capacity filled to 20%, 50%, 80%, maybe 1%. We just never know. That's point number one. Number two, B12 in serum or plasma is carried by two major protein carriers. One is called haptocorrin, the other one is called holotranscobalamin, okay? Notice as illustrated here, the bulk of B12 is carried in haptocorrin. Well, here's the problem. We do not know of a single physiological effect of haptocorrin, okay? It's circulating, it carries B12, but it does not deliver B12 to a single cell, okay? In other words, it is useless. On the other hand, holotranscobalamin, also known as holotranscobalamin 2, carries less of the B12. It may carry up to 20% or perhaps even less. And this is the carrier that has actually physiological function. All B12 that is carried into cells is carried via holotranscobalamin, okay? But it is possible that all of B12 in the serum will be attached to haptocorrin, and zero or virtually zero B12 will be attached to holotranscobalamin. As illustrated in this particular study, this is a German study with pregnant lacto-ovo-vegetarians and women described as low-meat consumers. Notice here we have serum holotranscobalamin, okay? And here we have means as well as range. So the range here is from 0 to 51. That's for women in the first trimester, and then 0 to 38 for women in the second trimester, 0 to 23 for women in the third trimester. That means that at least one of the participants in this study had holotranscobalamin equal 0, means there was no B12 attached to it, you see? And so let's assume that for this particular individual, she's got enough vitamin B12 stored in the body for 10 years. Let's assume that, okay? That is completely irrelevant. Why? Because she has no B12 attached to holotranscobalamin. Holotranscobalamin carries B12 that was delivered into the body through gastrointestinal tract. okay? And so whatever amount may or may not be stored is simply irrelevant. In addition, I want you to consider the findings of a couple of studies here. This is a study with 15 vegans. They were vegans for over 2 years. And during this time, they used B12 supplements, either in the amount of 3 to 10 micrograms per day or 2,000 micrograms per week. Okay, either one, either 3 to 10 micrograms per day or 2,000 micrograms per week. Okay, the nature of the experiment was such that for the duration of the experiment, they were to stop using these supplements. Okay, so up until the beginning of the experiment, they were using supplements, and then they stopped using the supplements. And notice what happened here. Each line that we see in here represents an individual in the study. Notice that in 3 months period, there is a relatively rapid decrease in vitamin B12 concentration here in the serum. That is accompanied by increase in homocysteine, which is a confirmation that there is a lowering of vitamin B12. When we look specifically at the findings, on average, almost 25% decrease was noticed in 3-month period of time of the study from the beginning until, again, the measurement was taken 3 months later. What this indicates is that B12 deficiency can develop relatively quickly. It doesn't have to be taking months or years. And notice that this is in picograms per milliliter, and so this mean of 196 is already below the traditional cutoff for deficiency. You see? Here's a finding from a different study, and in this study they had 13 individuals in one group and 10 in another group. And again, they used B12 supplements or fortified foods with B12, and then they stopped for the duration of the study, which was 2 months. And in 2 months, there was a decrease in almost 35% here for one group and 34% for another group. So the point is, again, that it does not necessarily have to take many years for vitamin B12 deficiency to develop, you see? All right, so let's look at the last one. Not just strict vegetarians or vegans may require B12 supplements. And this is one of my studies, and what we reported is that the deficiency rates reported for specific populations were as follows: 62% among pregnant women, between 25 and almost 86% among children, 21 to 41% among adolescents, 11 to 90% among the elderly. More importantly, notice, the main finding of this review is that vegetarians develop B12 depletion or deficiency regardless of demographic characteristics, place of residency, age, or type of vegetarian diet, okay? So we are not talking only strict vegetarians called vegans. Regardless of whether we are talking lacto-vegetarians, ovo-vegetarians, or even pesco and semi-vegetarians, they are at a high risk of developing B12 deficiency. I have more data here. This is from the subgroup of the Adventist Health Study from Loma Linda, and this is data for homocysteine. Remember, for vegetarians, B12 status is the main determinant of homocysteine. And we can see very clearly here that homocysteine equal or above 15 was noticed in 45% of vegans, 30% of lacto-ovo-vegetarians, 32% pesco, and so on and so on. Vitamin B12 deficiency is common in all participants of the study, and more so in the vegetarian groups. Let's look at another myth / misconception. Methylcobalamin is superior to cyanocobalamin. That's part of that myth. And then the other part is people should not be using cyanocobalamin because it contains cyanide. Okay, this is a relatively common view. Let's examine this. Okay, number one, where does it come from? Okay, or what is it based on? So remember I mentioned in the beginning that there are two active forms of B12. One is called adenosylcobalamin. The other one is called methylcobalamin. So people who promote methylcobalamin claim that, well, methylcobalamin is the active form of B12, so this is what we need to use, and the others are not as good, and cyanocobalamin is not good because of the cyanide part of the compound. However, notice what we find in this particular publication. At doses commonly used in treatment or prevention of cobalamin deficiency, all cobalamin forms appear to be absorbed, internalized by the cells, and follow the intracellular metabolic pathway that converts all forms into the common intermediate, cobalamin, that in its turn transfers into the functional coenzymes methylcobalamin and adenosylcobalamin. Okay, so what the quote implies is that regardless of which one we take, whether that's methylcobalamin, cyanocobalamin, adenosylcobalamin, hydroxycobalamin, that methyl part, cyano part, hydroxy part are split off, and we are left with just the cobalamin, which then goes into the different pathways of B12, and depending on the need, the body generates whether adenosylcobalamin or methylcobalamin. So it is an incorrect assumption to think that because we are ingesting methylcobalamin, that methylcobalamin will be used on cellular level. Okay, it is just simply not the case. Let's look at the other quote. Methylcobalamin and cyanocobalamin show very similar biological effects, but cyanocobalamin may be superior as oral supplementation because of its stability. Okay, methylcobalamin is not stable, and so if you keep it long enough on the shelf, you know, it may say on the label 500 micrograms, but there will be little left because of instability. It was just degraded into whatever other compounds. Cyanocobalamin, on the other hand, is stable, so we can use it again in food fortification, in supplements, and it will not degrade as readily. On top of that, notice also that in one study, this is data from a Norwegian study, average intake of cyanide from foods in Norway is about 95 micrograms per day. Okay, intake of those in the 95th percentile of cyanide is about 372 micrograms per day. So among those with the highest intake of cyanide, it is close to 400, as this data shows. And then notice the amount found in 1,000 microgram of cyanocobalamin is 20 micrograms, okay? 20 micrograms. And so in comparison to how much cyanide we get from cyanocobalamin to the amount of cyanide that we get from foods, we get several times higher amounts from foods. And so people who say that we should never be using cyanocobalamin should simply stop eating altogether, because from the foods that they ingest, they get more cyanide than what they will get from a supplement. Of course, whether from foods or supplements, we ingest such small amounts that they have no really toxic effect, because if you compare again the dose into the lethal dose, it's just simply not enough. Okay? Myth number 3, vitamin B12 causes cancer. And I actually learned of this myth several years ago, I think about 8 years ago, when I had some lectures in Poznan in Poland. someone asked me a question during questions and answer sessions regarding this particular problem. And I understand that physicians in Poland hesitate to give whether B12 injection or supplements because they fear that that may actually cause cancer and may help cancer cells to grow. And apparently, these physicians, again, I know this secondhand from individuals who came to my lectures. Apparently, these physicians refer or base their belief on whatever Norwegian study. I'm not sure what study that is, but I found a study based on people from Denmark. And in this particular study, with a lot of individuals, notice over 300,000, and over 19,000 of these individuals were receiving B12 therapy, and over 22,000 developed cancer in the period of time of the study. Here's what they found. They found that there was a correlation between a variety of different cancer types and serum cobalamin levels. You can see here, especially when it comes to hematological cancers, as well as smoking and alcohol-related cancers. That will be pharynx, larynx, for example, neck cancers, things of that nature, okay? They found a correlation. In fact, when we read the specifics, notice that for gastric cancer, those whose B12 was above 800 in comparison to those with lower concentration had more than 13 times higher risk for gastric cancer. For colorectal cancer, it was more than 5 times higher. For liver cancer, it was more than 40 times higher. Pancreatic, more than 15. Lung, more than 9. And so on and so on. Renal, notice urinary bladder, and others, especially here when we look at this one, myeloid malignancies, more than 105 times. So when I look at this study, I was thinking, wow, is there a single more important factor in cancer prevention than B12? Because it seems, based on this data, that B12 would increase the risk by so many times, a few to several dozens of times. So there might be something going on in this particular study. And especially I like to think that because the findings from that study do not quite match with the findings that we know from other studies, including a few meta-analyses that were published. Notice, for example, here we have data, this is meta-analysis, on B12 and breast cancer, okay? And so we have here serum vitamin B12 as well as dietary vitamin B12. And what pattern do we see in here? Even though this is the finding here is that there was a non-statistically significant decrease for serum B12, but the patterns seem to be indicating that there might be actually some protective effect. Okay, the same when we look at the pattern here for dietary intake. Again, it seems that B12 may actually be protective. And we actually do have here statistically significant decrease by 12% for breast cancer. Here we have data for lung cancer, okay? Not much going on here, but if anything, again, there might be actually a decrease here when it comes to B12. When we look at homocysteine, again, keep remembering that homocysteine is largely impacted by vitamin B12. Increases in homocysteine were associated with higher risk for lung cancer, okay? And so if anything, again, we can see here protective effect. Pancreatic cancer, not much going on here, right? 0.97 notice for dietary intake. For blood analysis, again, not much going on here. Colorectal cancer, we find that past certain intake, there might actually be, again, protective effect of vitamin B12. And here we have more data for colorectal cancer. And again, the pattern seems to be that it might actually be somewhat protective, or at least it would not be detrimental. Okay. Here we have for B vitamin supplementation, so not just B12, but also other B vitamins. And here's data on cancer incidence, death due to cancer, and total mortality, okay, based on a number of different studies. And we have here doses for vitamin B12 included in these different respective studies. And what we find is for cancer incidence, again, there is no impact whatsoever here, okay? When it comes to cancer mortality, there is no impact whatsoever. When it comes to total mortality, again, there is really no impact. Notice the relative risk is 1.00, so there is no impact whatsoever. So we have very compelling data to believe, and this data is not just from prospective studies, but also from randomized studies, to conclude that B12 does not increase the risk of cancer. I actually have a separate webinar on vitamin B12 and cancer, and here's the conclusion that I made in that webinar based on a number of studies that I reviewed. Randomized studies do not provide evidence that vitamin B12 causes cancer. There is no credible evidence that vitamin B12 supplements cause cancer. Evidence that high serum B12 causes cancer is lacking. And then lastly, high serum B12 may be considered a biomarker for cancer. What do I mean by that is, it is not that high B12 causes cancer. It is that cancer causes high B12. You see, there's actually a good data that shows that that's actually the case. Remember, I mentioned that there are two major carriers of vitamin B12, one of which is haptocorrin. Haptocorrin is secreted by such organs as the liver, the lungs, kidneys, some others, okay? And so when you have especially cancer of the liver and other liver conditions, such as, for example, non-alcohol-related fatty liver and cirrhosis of the liver, okay, that diseased liver and other compounds, such as, again, lungs, kidneys, and so on, secrete unusual amounts of haptocorrin. So we find elevated serum B12 because there is a lot of B12 in that circulating haptocorrin. But that is a result of having cancer and or other underlying conditions, such as those that I mentioned, rather than B12 causing cancer because we have, high B12 in the blood. All right, let's look at another one, myth or misconception number 4. The role of B12 and homocysteine in cardiovascular disease is controversial. Okay. First, let me just establish that homocysteine is a risk factor for cardiovascular disease or atherosclerosis. Notice this quote: each increase of 5 micromoles per liter in homocysteine level increases the risk of coronary heart disease events by approximately 20%, independently of traditional coronary heart disease risk factors. Okay? It's important to point out that this is an independent risk factor, independent on the cholesterol level, on smoking status, on blood pressure, and things of that nature. Okay? So homocysteine increases the risk for coronary heart disease. Okay? Notice this is from one of my papers. I concluded results of 6 of 7 recent meta-analyses support the association between hyperhomocysteinemia and increased risk of cardiovascular disease. Now, if you have 6 out of 7 meta-analyses supporting a given association, is that association controversial? The only reason why one of the 7 meta-analyses was not or did not show statistically significant association between homocysteine and cardiovascular disease is because it was meta-analysis of studies in which participants were given B vitamins to lower homocysteine, and then they looked at whether that lowering of homocysteine would decrease the risk for cardiovascular disease. The problem with these studies, or with the findings, was that the homocysteine was not lowered enough. Okay, so in order for homocysteine to actually have an impact, it would have had to be lowered to less than 10 micromoles per liter. In some of these studies, it was 11, it was 12. So they lowered the homocysteine, but not large enough to see any impact. Okay, it is one of the most proven association that is supposed to be controversial. Of course, I'm sarcastic, it is not controversial at all. Myth or misconception number 5. Vegans' needs for B12 is lower compared to non-vegetarians. Where does this come from? Well, 2 quotes. It is quite likely that the vegan diet would require no more than 0.05 micrograms of B12 daily. This was taken from a book, one that is in English as well as in Polish. I didn't include the authors or the title because both of the authors are deceased now, so I just didn't want to, put their names by this quote here. And the other one that says there are several reasons that the B12 requirements suggested for normal people may not apply to vegans. There is no reason, but that's what, again, the claim is. Let's look at this study. This is a study known as the Adventist Ministers' Health Study. It was an Australian study with 340 ministers, and 245 of them were either lacto-vegetarians or vegans. Here we have B12 for these. They documented large percentage of deficiency of B12 in these individuals. But the important part for considering that myth is in this quote. Notice, data from the dietary questionnaires supported dietary deficiency as the cause of low serum vitamin B12 in this population of lacto-ovo-vegetarians and vegans, 56 of whom consumed sufficient servings of vitamin B12 containing foods to obtain the minimum daily maintenance allowance of the vitamin, which was, according to the authors, 1 micrograms. Okay, regardless of whether that 1 microgram or not is adequate or not. Notice that the quote implies that 56 or 23% of those with B12 deficiency ingested 1 micrograms or higher amounts, and yet they were what? They were B12 deficient. Of course, 1 microgram is, if I go back here, is some 20 times higher amount than what is suggested here in this quote as what is actually required for vegans. And so this is all taken from the thin air. There is no support for this view whatsoever. Myth number 6. Vitamin B12 is found in various plant products. Okay, and here's where this comes from. There are several vegetarian food sources of B12. These include wheat, soybeans, various common greens, olives, fruits, roots, and stem of tomatoes, cabbage, celery, kale, broccoli, and leeks. The leaves of kohlrabi, seaweed, and alfalfa contain B12. It is difficult to avoid B12. Of course, this is pure nonsense. There is no B12 in this. If you find B12 on any of these, it will be a product of contamination. Okay, so the product was perhaps exposed to sewer or feces or soil or something to that effect. Okay, plants simply have no need for B12, unlike bacteria, and that's why plants do not contain B12. Just to support what I stated, this is by Dr. Victor Herbert. There is no active vitamin B12 in anything that grows out of the ground. storage vitamin B12 is found only in animal products where it is, this word means common or abundant, okay, and where it is ultimately derived from bacteria, okay. Here's another one. The vitamin is present only in animal source foods or fortified foods. This one is somewhat similar, this myth, to myth number 6. There are alternative sources of B12 for vegans and vegetarians. And here are those supposed alternative sources. Fermented soya products such as tempeh, seaweeds, living vitamin supplements made of plants. Those are products that you can find in the United States, for example, in different health food stores. Probiotics, plant foods, again, some plant foods listed, and even water. Okay, notice again from Dr. Herbert, we studied several types of tempeh, including the original soya tempeh, culture with a label claim of 160% of the USDA, US RDA, for vitamin B12 per 4 ounces. There was practically no vitamin B12 in it. We also studied most of the spirulina sold in health food stores as sources of vitamin B12. There's practically no vitamin B12 in them. The so-called vitamin B12 is almost exclusively analogs of vitamin B12. These are the pseudocobalamins that are not active. And we have extracted the 2 largest peaks of analogs, and they actually block vitamin B12 metabolism. Okay? And here's an example. Not as a study, this is a study with individuals who were vitamin B12 deficient. Okay? They divided these individuals into 2 groups. The first 5 individuals were in there what they call the vegan group, and then an additional 6 of them received other products, including fish, for example. So in the first group, they received, notice algae, okay, spirulina, nori, and so on and so on. When we look at plasma vitamin B12, interestingly, in 3 out of 5, it actually increased. Vitamin B12 in plasma increased. This would imply, would imply that we actually are correcting vitamin B12 deficiency. However, when we look at mean corpuscular volume, notice that in all cases, mean corpuscular volume is actually doing what? Is getting bigger, right? It's getting bigger, which means what? We are dealing with megaloblastic anemia. That is a result of vitamin B12 deficiency. So regardless of the fact, let's just take the first individual here as an example. Regardless of the fact that for this particular individual, after ingesting spirulina and nori, B12 increased 3-fold, right? Or 2-fold, I should say, from 130 to 378. Notice mean corpuscular volume also increased, indicative of having vitamin B12 deficiency. Okay? This is not the case for the other group. For the group that receive, in addition to spirulina and nori, they also receive fish. And fish is a source of B12. And so notice that an increase in plasma B12 is accompanied with lowering of mean corpuscular volume, which means we are correcting actually vitamin B12 deficiency. Here's a study with individuals who received a variety of different treatment options for B12 deficiency. Some of them received cyanocobalamin, a supplement. Others received nutritional yeast that was supplemented with B12. And then the other received probiotic. And what we find is, here's the findings. This is methylmalonic acid. In all cases here in the first group, and in most except for one, in the second group, we find a decrease in methylmalonic acid indicative of treating B12 deficiency. But we don't see the same impact among those that receive probiotics. In fact, 7 of 8 subjects normalized methylmalonic acid concentrations. Normalized meaning decreased methylmalonic acid. In the first group, those that received cyanocobalamin, 5 of 8 did the same for those who received nutritional yeast, but not a single one of those who received probiotics normalized methylmalonic acid. Now, there are many different probiotics, and we don't have a lot of studies on probiotics and B12, but the study that we do have indicates that probiotics simply is not a source of B12. So, conclusion, B12 deficiency is a worldwide problem. Only foods of animal origin naturally contain vitamin B12. High serum B12 does not cause cancer. Okay? Homocysteine is associated with increased risk of cardiovascular disease. Methylcobalamin is not superior to cyanocobalamin. Plant foods do not naturally contain vitamin B12. For more information, my book on vitamin B12 in Polish is available in various online bookstores in Poland. So I recommend, if you would like to learn more on this particular subject, to get one. And I know you cannot ask me questions because I'm recording this, but you are more than welcome to send me an email. My email is pawlakr@ecu.edu, and I will be happy to answer any questions you might have. I hope this was helpful, and I'm glad that you are interested in vitamin B12 and my particular view on this particular vitamin and this particular issue of misconceptions of vitamin B12. Thank you.